Hello and welcome to today's webinar for mental health professionals, Addressing Racism to Reduce Mental Health Inequities. My name is Sasha Zacard and I am the Education and Membership Manager here at ADAA. Before we get started, I would like to go over a few items so you know how to participate in today's webinar. We've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right corner. You have joined the presentation listening to your computer's audio by default. If you would prefer to join over the phone, just select phone call in the audio panel and the dial-in information will be displayed. Please note this webinar is being recorded and will be available as an on-demand webinar within 24 hours. All attendees should ensure they remain muted for the entire presentation to avoid background noise and distractions. You will have the opportunity to submit text questions at any time of the presentation by typing your questions into the chat box of the control panel. You may send in your questions at any time. We will collect these and address them during the Q&A sessions throughout the presentation. For those who purchase CE/CME credit for this webinar, you will receive an email with a link shortly after the completion of this webinar. This link will include the webinar survey and post-test questions required to receive your CE/CME certificate. Please reach out to webinars@adaa.org if you have not received this link. I would like to now introduce Dr. Briana Woods-Jaeger. Dr. Woods-Jaeger is an assistant professor in the Department of Behavioral, Social, and Health Education Sciences at Emory University and a licensed clinical psychologist specializing in traumatic stress and culturally responsive interventions. She received her PhD and MS in clinical child psychology from the University of Washington. Dr. Woods-Jaeger's research examines social and structural processes that link the experience of child trauma and adversity to mental and physical health disparities. Her work focuses on partnering with communities to identify ways to prevent adverse childhood experiences and support different systems such as education, juvenile justice, and healthcare in responding to the needs of trauma-exposed youth. Thank you for joining us, Dr. Jaeger. There will now be a brief moment of silence while I pass over the presenter role to her.
All right, can everyone see my slides? Let's see if I can see the chat. Okay, great. So thank you for that introduction. I'm really happy to be here with you all today to discuss addressing racism to reduce mental health inequities. And I'm just going to adjust some of these things on my screen so I can make sure to see you all. So what I'm hoping to cover over the next hour is to discuss how structural racism impacts trauma exposure and response among Black communities, then define some core principles of cultural humility that we can use to address mental health inequities, and spend the bulk of time talking about applications of these principles to address racism and mental health inequities. And I really want to have time for questions and discussion, so I'm going to do my best to stay on time so that we have plenty of time for that as well. So just to start, I wanted to provide a general definition of structural racism and then discuss how it relates to trauma disparities in particular. So structural racism refers to mutually reinforcing and equitable systems that in turn reinforce discriminatory beliefs, values, and distribution of resources, increasing risk for negative health outcomes. So there's a lot in there, but really what I want to emphasize is that this is multi-systemic, which means that multiple different systems working together are really generating these inequities. And when we think about it in relation to trauma, various systems that have historically and currently generated these inequities produce an environment where there's an increased risk to trauma exposure among Black youth, and also where there's more limited access to resources, services, and support for trauma-exposed youth. So really kind of seeing it at both ends of this. And so it's really important for us to be thinking about this in terms of both prevention and treatment. And then I want to particularly hone in on racial trauma among Black
youth. I just want to stop you real quick. We can't see the slides advancing.
Slides?
Yes.
Okay. Sorry about that. All right. So did you all not see the previous slide then? I'll just kind of go back. So this is what I just reviewed in terms of structural racism. And then now I wanted to really focus in on racial trauma. So when we think about racial trauma, just a general definition, this is referring to the psychological and emotional response to racism-related experiences that are perceived as threatening. And so a lot of the work in this area is really highlighting the impact of interpersonal racial discrimination. And what we know about this is that Black youth experience this at a high level, so it's very frequent, with one recent study demonstrating up to 5 experiences of racial discrimination a day, that Black youth were reporting this when you include online discrimination. So this is a frequent experience, and we know from a bulk of literature that it's associated with a number of mental health outcomes, including anxiety, depression, and suicidal ideation. So I would say this is the area where we have the most research and are really focusing our efforts in terms of how we can address this. But it's really important for us to recognize that racial trauma is impacting Black youth in multiple ways beyond the interpersonal. And so we think about it at the systemic level. This is when we're thinking about things like the school to prison pipeline, mass incarceration, these systemic issues and manifestations of racism that are impacting Black youth. The historical and generational aspect of this. So thinking about, there's policies that were enacted in the 1930s that are still having an impact when we think about concentrating poverty and what that does in terms of increasing risk to trauma. There's generational impacts where some research is now looking at parents' exposure to racism impacting their child's mental health over and above the child's own exposure. So that's something we really need to be thoughtful of as mental health professionals, and how are we supporting parents? And then this cumulative and ongoing nature of it. And so unfortunately, these are not experiences that are one-time sort of acute experiences. They're often frequent up to the point of being daily. And particularly when we look at some of the microaggressions that people are experiencing on an ongoing basis, we see this accumulation of stress that comes from those. And then finally, I really want to highlight the vicarious nature of racial trauma as well. And when we think about what's currently happening in our country, how often we are seeing on the news and how often Black youth are seeing on their social media, police killings repeated over and over, and having this consistent trauma exposure is very concerning and is definitely impacting their mental health. So I wanted to also elevate the voice of Black youth in this conversation, because I think it's really important for us to understand from their perspective what this experience is like and how it's impacting them. So we recently completed a qualitative study where we did 5 focus groups with African American youth, and we really wanted to understand their experiences of community violence and what we could be doing to promote resilience and recovery. So the average age of youth in our study was 16, and I also want to highlight that their average ACE score was nearly 6. So these are youth that have a high level of trauma and adversity that they're navigating in addition to racial trauma. And what came from the study, so we were focused on community violence exposure, but what we heard repeatedly and most commonly was this experience of racial trauma and the multiple ways that it was impacting them. So I'm just going to share a few quotes. So one youth shared with us: "There's not a law that says it's okay to kill a Black man in a car, but we see all these white cops killing Black men and it's okay." So here again, referring to that vicarious trauma of witnessing this repeatedly, even if you don't have the direct experience per se. Also this idea that, and it's okay. So this idea there's not justice, this kind of keeps happening, and what that does to someone's mental health. Then thinking more of these daily hassles, one youth shared with us, and that kind of irritates me when I want to go somewhere and the police is just all up on me, like trying to see what I'm doing. I just came to chill and have a good time like everybody else is doing, and I'm the one that's getting stopped and I'm the one that's getting questioned, and I don't have nothing to do with it. So this kind of daily hassle or frequent experience out in the community was one thing that youth were sharing, as well as it happening within specific systems like schools. So the white principal, she took my backpack and she went through it. For what? I don't know. I was the only Black kid in class that day, and so she looked in my backpack. So again, the youth were sharing with us how this experience crosses different systems, crosses different areas of their life, and is really impacting them in a variety of ways. In addition, something that came from this study, and again, it goes back to what I was talking about with structural racism really inhibiting the response and supports available to youth, is that Black youth are experiencing that there's not a response to this. that they're constantly bombarded with these traumas and experiences, and not having support or services there to help them go through it. So for example, one youth shared with us, at first, police don't even be there on time. A little boy died because the police canceled or hung up the phone, like they don't get there early enough. So really feeling like they're out there on their own without folks to protect or help them when they go through these severe traumas. They have all these signs around school, no bullying, no bullying. We telling y'all these kids, some of these kids are suicidal and you all doing nothing about it. So again, this lack of response to a significant mental health concern that Black youth are seeing in their communities. And finally, we really don't have no places that can help. It's always like somebody that's going to die in the beginning of the school year. Everybody really ain't going to know how to cope about it. And so this is really disheartening. I mean, again, that they're recognizing the high level of trauma and that there's no one helping and that people don't know how to cope. So there's a lot of unaddressed mental health needs that we really need to be paying attention to. As mental health professionals, and I hope we have time to discuss this, I think for us to really be thinking about how we can be involved in other systems outside of the clinic to really be able to provide these supports and services that we are so well trained to deliver. So in addition to this high level of racial trauma that's being experienced by Black youth, there's also racism and systems of care that are designed to respond to youth trauma. And so what we see in mental health care is that Black youth experience less access to care, a lower quality of treatment, and higher rates of misdiagnosis. So this is something, of course, that people are trying to address, but it consistently is persistent in terms of being a disparity that we have not figured out. In terms of child welfare, we see that Black youth are half as likely to receive mental health services after accounting for mental health need, meaning they have, when we have the same level of mental health need between a Black youth and a white youth, Black youth is half as likely to receive those services that are needed. And then in schools, and again, I would say schools are not designed to be mental health providers, but unfortunately, because of the high rates of trauma within schools, they have been put in a position where they are often on the front lines of responding. And what we see in schools, while there's a big effort, and I'm really excited to be involved with a lot of schools that are becoming more trauma informed and really trying to build up those resources and supports for youth who have these experiences, Black youth experiences, particularly of traumatic loss, is really not addressed. There's not, again, going back to what we heard in the focus groups, but also what we know from the literature, there really isn't a response. And often if there is a response, it tends to be more punitive because people are really responding to the behaviors. And we know that trauma-related symptoms such as behavioral problems and academic difficulties, if they're not responded to in a trauma-informed way, often are going to a more disciplinary response rather than support. And we're really concerned when we look at disparities in discipline. And so students of color comprise 79% of school-based arrests and 80% of referrals to law enforcement, despite only representing 39% of the national public school population. And so not only are they being disciplined, but disciplined at such a level that it's reaching law enforcement. So they're then going onto that trajectory, that school to prison pipeline. And discipline disparities are particularly high in subjective categories. And that's where we're starting to see the role of implicit bias. And so when we think about those categories like insubordination or defiance, where it can be tone of voice, the way the student approached me, these categories are particularly problematic, the disparities we see in them, because they're not objective. And so really thinking about how we handle that is important. So all of this is to say that these issues that we see in terms of structural racism and racial trauma, they are pervasive, they're in multiple systems, but I also want to emphasize that they're preventable. And so that means that we have an opportunity as mental health professionals to really be involved in this work of dismantling racism, but it requires us to have, the tools and supports and resources to get engaged in that way. And so what I want to offer today is an approach for us to consider in terms of how we can be more involved in dismantling racism and addressing racial trauma. And so that approach that I'm going to share is cultural humility. So first, just to give a general definition and some key aspects of cultural humility. When I say cultural humility, I'm referring to this commitment that we make to active engagement in a lifelong learning process. That we're going to be engaged on an ongoing way with our clients, with the communities that we're working with, our colleagues, and ourselves. So it's multifaceted, And I think that really suits it to dealing with an issue that is so systemic and multifaceted, because we're going to have to be in this for the long haul, and we really have to have an approach that encourages us to consistently be learning and working in multiple ways and partnering with multiple people to do this work. So cultural humility offers us a strong foundation for that. It really begins with self-reflection. And so that's one of the aspects I think is so important with cultural humility, is that it requires us to really understand ourselves and our own cultural identity and what we're bringing to our interactions and to the partnerships that we form, and an openness and humility to understand others in order to build authentic and trustworthy relationships, and I would also say partnerships. So this is really important for us in terms of thinking about a way that we can be involved and engaged in some of this work. And there's 3 core principles that I want to highlight today. This lifelong learning and critical self-reflection, this emphasis on mitigating power imbalances, and this is in the clinician-client relationship, but also in the clinician-community relationship, and then really being thoughtful about institutional accountability. And I know that often, as mental health professionals, we might not have received training specifically in that area, but there are a lot of ways that we can contribute and partner, which I will highlight a few examples. So in terms of applications of this, what I'm going to highlight today are just 3 different areas. There's many more I'm sure that we could discuss as well. But that I'd like to offer today. So the first, in terms of critical self-reflection and lifelong learning, really thinking about how we can investigate and examine our own cultural identity, our biases, and our privileges, so that we're again in a position of really being able to build more authentic and trustworthy relationships, where we recognize our own social location, what we're bringing to the interaction or the partnership. In terms of power imbalances, really thinking about how we can have more effective racism-related communication, and thinking about this both therapeutically and really being able to address racial trauma more effectively and have those discussions about even racial microaggressions we may commit in the therapy space, but also thinking about it broadly and how we can promote and really support those conversations at a more of a general level. And then thinking about our role and thinking about policies and practices within the institutions that we are a part of. So first, in terms of this self-reflection component, I want to offer a tool called the Cultural Identity Inventory. And this was developed by Dr. Cheryl Hyde, and I have used it in multiple ways that kind of adapted it to really be a training tool, but also a great tool for supervision and for consultation, because it offers something not only for us to look at internally and really do our own self-reflection, but also to really start sharing this with others to explore how our cultural identity impacts the work that we do. So the purpose of it is to really develop a more comprehensive understanding of our cultural selves, and this is referring to the values and beliefs, practices and experiences that shape who we are and how we act. And what I really like about this inventory is that it recognizes the complexity of cultural identity. So we're not just one thing, there's not just one cultural attribute that's important, there's multiple ones. And so thinking about the dynamic nature of our cultural identity, the fluidity, so a really important piece to recognize is that in different settings, there might be different aspects of our cultural identity that are particularly salient for us or that are particularly salient to others. And so recognizing that, like when I'm at work, there's certain aspects of my identity that may be more salient than when I'm at home. When I'm working with a client, there might be certain aspects. So just being aware of that and having a tool that can help us think thoughtfully about that. And the idea behind this is that as we have a more comprehensive understanding of our own cultural identity, we are better situated to build authentic relationships with others that really appreciates their cultural identity. It has an open and creates an openness and a space to explore that. And this is so important because one of the things in terms of racial trauma, when we think about some of the coping skills and the interventions to address it, cultural identity and racial identity in particular is so important as a protective factor. And so being able to really make space and kind of boost our own understanding of that is really important to be able to best serve our clients. So these are just different cultural attributes that we can consider when we're doing a cultural identity inventory. And I want to highlight that other bubble because it's so important to say this does not cover everything, of course, but it does give us a place to start. And when I'm using this as a training tool or in supervision, I really encourage people to think about the ones that are most salient to them, but to not shy away from race ethnicity. Often there might be sort of a tendency to do that because we tend to be more uncomfortable And so really encouraging people to fully explore this, but to make sure that they take a look at that race ethnicity attribute. And as you look at these different attributes and do some self-reflection, in Dr. Cheryl Hyde's version, there's a lot of different questions that you can ask, and it's very comprehensive. We've sort of honed it down on some that are really key and helpful in terms of, again, in training context for us to consider. I typically ask people to think of 1 to 2 aspects that are most salient to them right then. So to kind of ground it in that way as we're doing this exercise. And then ask them to consider 3 questions. What are values and beliefs that are associated with those aspects of your identity? What privileges do you have or not have based on those aspects of your identity? And how do you think clients experience those aspects of your identity? And the idea with these questions, again, is just to stimulate that self-reflection, thinking about, the things that are associated with our identity that we really consider to be strengths, values, things that are important to us. Also thinking about things that we might have in terms of privileges, or maybe privileges that we don't have and how that's affected us. And then really being able to think not only of our own perspective on this, but how it might be perceived by others, because there often is a disconnect there. And particularly in areas where we may have a more privileged status, that might be less salient to us, or we might take that for granted, whereas for a client or someone who does not have that privileged social identity, that may be very salient to them. So being able to really be thoughtful about that and take the time to explore it, with really the goal of thinking about how your cultural identity might impact your work with clients. And so again, as we use this as a tool, it can be a self-reflection tool where you do it on your own, and I encourage people to do it regularly, so not just look at it once, but kind of have an ongoing process of checking in. But also it's really powerful to share this with others. And really thinking about environments where you can share it with colleagues, or even share it with friends, family, just to get that practice of really considering this more and being able to talk about it. And so when we do this again in a training context, we'll ask people to reflect on just their overall reactions to the identity inventory. What was it like? What do they think about it? What stands out to them about their own self-reflections? And then how could they use this as a tool to improve their relationships with clients who have different cultural identities? And so just again, thinking about how can this be useful to us and serve as a way to really operationalize or apply that principle of cultural humility, lifelong learning, and critical self-reflection. And then also really encourage folks when they share to practice mindful listening. And this, of course, is a skill many of us have in many contexts, but when we get into certain areas, particularly maybe areas that we're less comfortable with or just have less experience discussing, it might be harder for us to do this. So really intentionally practicing this when we're sharing our cultural identity inventory. So listening with curiosity and a willingness to learn when someone else is sharing, resisting that desire we might have to interrupt or maybe to fix something if someone shares something painful, or to figure out what we're going to say next and make sure it's like the right thing to say, trying to resist that and let it go, and really being fully present to listening to the other person to understand their experience from their perspective. So we really encourage people to practice this, again, repeatedly, but often in a training context, this can be an exercise that you do, and you can really see it stimulates a lot for people that they can then take on in their own self-reflection ongoing. All right, I'm just check my time. Okay. So in that same self-reflection space, it's really important to look at implicit bias and racial bias in particular. So there's a lot out there about implicit bias. I'm just going to offer a general definition of what I'm referring to. These are those judgments or assumptions about people that we make based on specific associations we've developed from experience or culture or media, and it affects our actions and decisions in an unconscious way. So we're often not aware that we have these, but they affect the way that we act. So that's important to recognize. And the thing that can make it difficult to do self-reflection around these is because often they don't correspond with our values and beliefs. For many of us, if we hold a value of equality, treat everyone the same, justice, and then have to look at places where we have negative bias against certain social groups, that can be very painful. And so this makes it sometimes an area that people don't want to reflect upon as much, or maybe want to avoid. And also people might feel like, well, what can I do about it? And so what I really encourage people to recognize is that we can't do much about it if we're not aware, but there are things we can do to mitigate harm once we are. So it really is important that we take a look at this consistently. So some of the ways that we see this show up again, particularly in some of these systems that I mentioned earlier. So in mental health care, a recent study demonstrated that working class Black men are less likely to get a call back when requesting mental health treatment compared to middle-class white women, despite reporting the same symptoms, having the same health insurance, and preference for appointment time. So they really tried to take off, all those issues that may be reasons why people wouldn't get a call back or not be able to get an appointment, and found that they were less likely to get that call back. So again, we have that barrier to accessing care. And then in education, we see this as early as preschool, where a recent study looked at with preschool teachers, they primed them to look for misbehavior, and they used eye tracking software to kind of see where they went with that. And what they noticed is that they more closely observed Black preschoolers when challenging behaviors are expected. And so obviously, if you look more for one person, you're probably going to see it more there. And this is starting as early as preschool. So you can imagine how that plays out across the education trajectory. And then Black boys, we also know that they're viewed as 4 to 5 years older than they are. And we're seeing how this plays out again with the police brutality, with Black boys being perceived as threatening as young as preschool. So this is very concerning. And so these things can cause significant harm. And if we're not aware of them and we haven't put things in place to really mitigate that harm, they continue to operate in this way. And so it's important for us to reflect and be aware of these implicit biases in order to address their influence on clients. And I would say, again, that self-reflection is important, being aware of our own, and also being aware of how these are playing out in different interactions that our clients may be having with different systems, including our own, and what that does, and what that might mean for our own relationship with them or for what they're carrying around every day. So for our own self-reflection, the implicit association test is a tool that we can use. I put the link there. And this has tests you can take in multiple areas, which I really encourage, because we obviously don't have bias in just one area. And also it can be a useful way, again, thinking about in a training context or supervision or consultation, to be monitoring something and really thinking thoughtfully about how are we going to mitigate harm from this. And so again, I want to offer that as a tool that we can use. So one way that implicit bias comes out is in racial microaggressions. And again, I mentioned these are those daily experiences. So they're referring to brief, everyday exchanges that send denigrating messages to people of color because they belong to a racial minority group. So include things like being followed in a store, having people clutch their purse or wallet while you pass, being told that you're a credit to your race. So there's a variety of ways that these come out, and they're associated with depression, anxiety, and negative affect. They're also commonly denied or minimized, which amplifies the harm. And so this is a point where I really want to emphasize, because again, this is an opportunity for us as mental health professionals to make sure we're not doing this, and really thinking about, in that self-reflective way, how can I be catching this in myself and helping my colleagues? So when we think about how this shows up in the clinical setting, there's a variety of ways, but some of the ways that have really been discussed and shown to be harmful are this denial or lack of awareness of bias. So again, that's where this important role of self-reflection and self-awareness is so key, not only of our own bias, but of other biases that our clients may have to have navigated. The dismissive or negating message about cultural issues, color blindness, so saying I don't see color. Again, that might come from a value of wanting that to be the case, but the reality is that we do. And so when we say that, what that communicates to a client is that we're not, it really questions their ability to trust us. And then culturally insensitive treatment considerations or recommendations. So again, it can show up in a variety of different ways. And what they've found in research, one study found that 81% of clients report experiencing at least one racial microaggression in the clinical setting. So this is a common experience in clinical settings. And these were mental health clients. And then another study found that when they've experienced a racial microaggressions, clients reported that 76% of clients report that it was not discussed. So it's happening frequently, it's not being discussed. And other studies have shown that it hurts working alliance. So this is important for us to really be thoughtful of, because it's hurting our relationship with clients. And you can then, see how it goes, but then it results in lower treatment utilization and retention. So this is important for us to be looking at within our own space. And then of course it is affecting other spaces that we talked about, like school and other areas that our clients are interacting with. So in terms of self-reflection, if we were doing like a workshop, which I would usually do these types of trainings, and we would have more time for self-reflection. But I encourage you after this webinar to really think about microaggressions that you've experienced personally. And you could experience these as a witness, that you've seen them happen, that you've committed it yourself, or that it's happened to you. So really bringing that to mind and thinking about the role that you played in that, how you felt and how you responded, and beginning to explore, what contributed to those things. Because for us to be able to address these, we really, again, have to have that awareness of how they're impacting us and also those that we work with. So I mentioned that there are things that we can do about this. So I've, kind of already talked about how awareness is such a critical component, and that people, especially, clients, are aware when we're aware. So it really is important for us to do that work to increase our awareness and understanding of this. But also to do things that are going to reduce our vulnerability to acting on implicit bias. So stress, meeting demands, anxiety, fatigue, all of these are vulnerability factors for acting on implicit bias. And so right now, all of us are probably particularly vulnerable, because I assume that many of you are experiencing these things right now. And of course, in our profession, we often experience this regardless of the time that we're living in right now. So because we are at increased risk, it's really important for us to think about tools for ourselves to help, again, reduce the risk of us acting on those. And mindfulness is one of those tools that has been shown to be effective in this particular space. And so when I say mindfulness, I'm referring to intentionally living with awareness in the present moment without judgment. And it can be practiced anywhere. That's something that I really want to emphasize, and I do particularly when I do trainings for people that are very busy and maybe have imagined mindfulness as like going to yoga retreats or 3-day meditation retreats, and don't think of it as something that they can do, is that you can do this anytime, anywhere, while doing anything. And I'll show in a moment some ways that we've really tried to break that down into some concrete practices for folks. And what we encourage people is to do this as often as they can, so they build that mindfulness muscle, because what we know is that it increases our awareness and self-compassion in the space of implicit bias, and reduces some of those vulnerability factors like stress and anxiety, as well as implicit bias and discrimination. So it has multiple benefits, but of course it is really hard to build in. And so what we've done is, working with very busy clinicians and educators, as well as parents, looked at what types of mindfulness practices could they integrate more to really build their mindfulness muscle. And so we offer these wellness cards, and these are just some examples of those mindfulness practices that you can practice, some of them in 1 minute or less, to really help, again, get more of that experience so that you start to see some of the benefits over time. We always tell people, of course, the more you can practice this, the better, particularly if you want to see some of those effects that we've seen, in research studies. But we do know things like putting a name on your feelings, that in of itself regulates your emotion. And so these are things that are practical for people, and we encourage, particularly as mental health professionals, we're often preaching this to our clients or encouraging them to practice mindfulness, that we really take the time to do this ourselves, and particularly do it with the intention of addressing those implicit biases and racial microaggressions that we've reflected upon by doing this self-reflection work. All right, so here's, I really like this model that Burgess and colleagues provided around ways you can think about having a mindful response when implicit bias arises. So we know these are going to happen. Often, again, we're not aware of it, but if we bring mindfulness in and we become more aware of when we're having these reactions, really kind of thinking about how we could break that down. So first, becoming aware of emotions is really important, because again, those vulnerability factors for us acting on implicit bias, if we can catch those early, it kind of sets us up to be able to hopefully catch the implicit bias. So I'm going to just share an example that's relevant to a lot of the work I do, which is working with Black families around parenting, and being parts of teams that are working on that, where a lot of implicit bias comes out in terms of how mental health professionals think about these families. So for example, if you go into, maybe you're doing something like PCIT, for those of you that maybe have experience doing that, and you're going to go into a session where you're going to focus on positive reinforcement, and you're going in already feeling kind of tense and frustrated, and maybe doing a little exploration. So this hopefully you're doing before you go into the session, kind of checking in with yourself. And then starting to look at what stereotypical thoughts might be going through your mind. So these are just some examples, and these are things that I've heard in consult meetings. So, positive reinforcement is not going to come easy to this mom. They're so harsh in their parenting, so negative. So these types of thoughts that, again, often they might just operate and we don't catch them, but being able to really recognize it. There might be some shame, of course, when we recognize it. So then being curious and really looking at this as an opportunity to increase our self-awareness so that we continue to go through this process and don't kind of push them away and then just move along. And ask yourself, what's going on with me that I'm feeling so frustrated? So kind of checking in, hopefully reorienting, and then doing whatever works for you to re-engage. So pausing and taking a deep breath. So again, those really brief mindfulness practices that we can do to kind of ground ourselves in the here and now, recognize what we just experienced, and then recognize that we can move forward. And ask more questions of the client, going in with really this openness to wanting to understand. And you've kind of prepared yourself because these biases came up, that I'm really going to intentionally focus on the strength-based approach to understanding my client. So asking them things like, what's most important to you in your role as a parent? What parenting approaches have worked well for you in the past? So really kind of shifting that narrative that maybe was going on and opening up a whole new opportunity to reattune to the client, to really connect with them. And hopefully then listening more carefully, you're able to be more present and really focus on that interaction. So this is just an example of how you can apply this in a situation where we're thinking about some of those biases that might come up in our clinical work. So the second area I want to talk about, and just mindful of time, so I'll kind of quickly go over, but then so that we can make sure to have time for discussion, is racism-related communication. So this is something that is really important, and many of us maybe didn't get training for this as mental health professionals, but now, it's very recognized how important it is that we have this as a skill set and that we're able to engage in these conversations. So one of the barriers to this is anxiety. It's anxiety provoking to notice injustice, especially when we benefit. And this is where doing that real self-reflective work is so important, and staying in it, because there, again, can be that tendency to push this away because it doesn't feel good. Right? And especially when we're a part of systems that are perpetuating these inequities, that can be very difficult. And when we think about race and racism, it's just especially taboo for us to discuss in this society. We don't have a good track record of it. Even within our training programs, we don't. And so it's really difficult for us to build these skills when there's so much kind of preventing us from trying. Particularly this idea of saying the wrong thing is a common concern that people have. And so what's important to recognize with this is that this anxiety and discomfort make it really important that we have an intentional plan to focus on it, because the tendency is probably going to be to avoid. That's kind of our natural response. And so thinking about how we can focus on these aspects of identity and of the work that we're doing while acknowledging the importance of other dimensions. So it's not an either or, and it's not that this is going to be the most important identity or issue to our clients. It may not be. So it's not that we want to come in always kind of solely focused, but it's important for us to have an intentional focus on it for ourselves because of that tendency to potentially avoid it. And so this is just an example of kind of what I just mentioned in terms of a cycle. So we have anxiety around discussing racism, so we don't talk about it. We feel some relief because it was like, oh, we didn't have that awkward conversation. We didn't offend anybody. We didn't say the wrong thing. But, ask people to consider what are the long-term consequences of that. And folks often are able to recognize a variety, but when we think about it with our clients, it again harms the relationship. It's not as authentic of a relationship quite often when this is an issue for clients. And it also feeds into more anxiety, and then we just kind of perpetuate this cycle. And so again, kind of thinking about that mindfulness theme and having more of a micro response to really recognize and be aware of your anxiety around this area, accept that, and then approach anxiety rather than avoid it by discussing it. Maybe you won't do it perfectly, but we'll talk about some ways that we can really think about having effective conversations. In the initial short term, there probably will be some discomfort, and there might even be some warning signs like, uh-oh, we're going to an area that I'm not comfortable in. I don't have experience with this. I don't know what to say. All those things come up. But often people find in the long term, when you stick with this, there's multiple benefits, particularly, again, when we think about our work with clients, increasing that connection and understanding. And then it leads us to do it more. And over time, the anxiety goes down. I'm not going to say it goes away, especially when, again, it's so reinforced in so many ways in our society, but it does get better, and we start to see more of the benefits or reinforcement from doing this and having these conversations. And I would say this isn't just with our clients, this is with our colleagues, this is with others, but really thinking about how being able to have this approach response to it can really enhance our work with clients. And so when we think about doing this, there's some key sort of skills or attributes I want to offer in terms of empathic communication, how important that is, particularly when we're dealing with racism or racial microaggressions. So the first thing is for us to be aware and open. So again, we've done that self-reflective work. We kind of know what our own biases are. We've hopefully also identified some of the negative emotions that come up for us. So I've talked a lot about anxiety, but often there's shame, there's guilt, sadness, pain, fear. And so really that we've examined that so that we have some tools to manage those negative emotions so that we can be fully present to our client's experience. So it's not about ours, but it's about their experience. And that we are really attending to our nonverbal communication. So we can kind of practice and feel like we have it down what to say, but there's a lot we communicate beyond words. And so really being thoughtful, and there's actually some interesting social psychology literature around racial distancing and how we actually physically distance ourselves from those who have a different racial identity. So really a lot to think about in terms of how we just set up these conversations and set up these spaces, I should say, to have these conversations. And then validation and empathy. So when people are like, what do I say? You know, really going to those clinical skills that we have that we often use, again, in many other areas, applying them in this area. So affirming the client. So powerful to just have someone be able to hear your experience and not challenge it, not get uncomfortable, not defend the perpetrator, but affirm you. And so that in of itself, reflective listening. So using that skill when having these conversations, naming racism. So not, you know, saying all these other things around it, but naming it flat out and acknowledging the emotion behind what the client is sharing. And I should say, or colleague, because these are conversations we can be having with each other and really should be having with each other as well. So these are just some tools to think about. And I'm going to go through this quickly because of time, but we often will give in our trainings or even in supervision vignettes of experiences that clients have shared with us and ask people to think about how they would apply these skills. So here's an example. Because of time, I'm not going to really go through it, but we would present, you know, what the situation is, what the African American youth shared about their experience, and then ask people to think about these things that we've talked about. So first of all, like what biases or judgments come up for you. We really want to get people to, like, again, practicing that sort of acceptance that we have these. If we can name them, you know, we can mitigate some of the harm. So what are they? And trying to get people to be more honest and authentic with that. And then going through, like, what would you say? What are some reflective statements you can make? What are other ways you would express empathy? And allowing people to explore in their own voice, because there isn't a script, you know, there's not like one thing to say in these situations, but there's certain principles that we can follow that tend to be more helpful for clients who share these with us. So getting people to have an opportunity to really practice that and sort of think for themselves, you know, how they will respond so that they don't dismiss or minimize it, which we saw often happens, unfortunately, in clinical settings. Okay, and then I'm going to shift now to talk about partnership and advocacy. And I know this is an area where often we haven't had as much training as mental health professionals, but we have so much that we can contribute in this area. So I just want to offer it, and hopefully we have some time to discuss ways that we can really be thinking about this. So this is really getting to that principle of institutional accountability with cultural humility and thinking about ways that we can participate in that process. So first of all, being an upstander, not a bystander. So finding ways to get involved, take action, and speak up. And if this is something that you can't do on kind of more of a you know, thinking about the macro levels, really thinking about even in a meeting, being able to speak up, when you notice things, saying it, getting that practice of really getting engaged and addressing these issues in more of a consistent way. And thinking about how we can flatten power hierarchies. And there's different ways to come at this, but often in our institutions, there are clear power imbalances that are based on race that have been there for a long time. And so we have to think very intentionally about how we can start to dismantle those, increasing representation, amplifying voices that haven't been heard or are not involved in decision making. So really being thoughtful about the different ways that we can participate in supporting that within our institution, including if we have a private practice within our practice. So being thoughtful about that. And then partnership. So of course, we cannot take all this on our own. It is multifaceted, it is complex, it is systemic. And so thinking about how we can partner with others who are doing this work or who want to do this work. And acknowledging that there are limits to our expertise and understanding, but we can still contribute and be a part of that. And then being persistent, because this institutional systemic work is going to take time. Unfortunately, you're not going to see the wins as quickly. And so you have to think about, how can I stay in this for the long haul? What do I need for myself to really be able to stay in this? And so a nice place to start is thinking about micro-intervention strategies. And so this is a paper that came out from Sue and colleagues and American psychologists in 2019 that really offered a way to think about how to intervene on these microaggressions that we, more and more recognize are impacting a variety of clients, but including Black youth. And so some different areas to think about with this is how can you, again, speak up? So making the invisible visible. So when you hear a microaggression, being able to name it and then challenge it. Disarming the microaggression. So expressing your disagreement, being able to really put yourself out there in that way to state what you think is important and describe what you see happening and what harm you might see happening. Educating the individual. So being able to really think about how you can offer this as an opportunity for us all to learn, and for being able to name things really clearly and plainly for folks to be able to have more of that authentic communication. And then seeking external reinforcement or support. So thinking about how we can support each other in this work. And really try to, over time, make our systems more equitable and responsive in these areas. So I just want to end with an example of some work that I've been fortunate to be involved with, where we've really looked at doing some policy advocacy. It started off very focused on clinical practice and with mental health practitioners coming to the table, along with early education providers, social services, public health, and parents who have lived experience of ACEs. And we all came together really focusing on how can we address toxic stress and this intergenerational transmission, particularly for families of color living in poverty. So this is a community-based participatory research project, but did involve several mental health professionals at the table. So while it's research, I still wanted to share it as an example, and particularly when we think about the policy that came out of it. So this is just a brief definition of CBPR. It's an approach to research that is really focused on partnering with communities, recognizing the unique strengths that they bring to the table, and beginning with a topic that's important to the community. So really having them identify what needs to be better understood, where we need to take action, and then coming together to really combine knowledge with action to achieve social change. And there's core principles of CBPR that you can see down there that very much align with cultural humility as well. And so this was the approach that we took in this project. And the way that we sort of provided an infrastructure for that is by forming a community action board that included the folks that I mentioned earlier, so from multiple sectors, as well as parents themselves who had lived experience, coming together to guide the research and clinical practice improvements that we wanted to work on within this community. And just for time, I'm going to kind of skip over and talk about, we did some qualitative studies, some iterative pilot studies to really look at clinical practice, and then focus on some of the issues we needed to address systemically, which led to this racial inequities and child welfare policy brief. And I want to share this because this was an area where we actually developed a practicum for a psychology practicum focused on this. So we had a psychology practicum student that worked with us was part of this project actually for 3 years. And over that time, using those principles of cultural humility, at first, again, we weren't focused on this policy brief. It came later as we were doing the research and seeing what emerged from it. And so the principles that we used, how that really came across in this was really looking at it from a research standpoint. So there's that critical self-reflection of ourselves, but when we think about what we've been trained in or what we've been exposed to, how can we be more critical in looking at that with a lens of equity? So recognizing racism, not just race. We see all these papers showing disparities, but how is racism playing a role in that? Looking at how we're mitigating power imbalances in terms of doing our work. And so incorporating local data, centering voices of those with lived experience, thinking about how we write or communicate for a non-research audience. And then doing that institutional advocacy and knowing that it's going to be ongoing. And so identifying and developing those champions that can help us along the way. So all of this work, again, it was a process, but it was we did this as kind of a pilot practicum to see how it worked and if it met the objectives also of a clinical psychology trainee and what they were looking for in terms of their experience. And so we were really excited about how successful it was. And in terms of the policy brief summary, you all will have access to these slides, so I won't go into it in depth, but essentially what we did was review the disparities that we know about, including incorporated some of the qualitative research out there that had really described families' experience of these disparities. We also included our own data from our CBPR project to really provide an overview of what some of the key issues were. And then we presented this to our CAB and particularly to the parents to get their feedback on, is this what we should be highlighting? Is this what's most important to communicate as we set out to really do this advocacy? And then what are the concrete recommendations that we need to think about for institutions? And it really came down to how mandated reporting was handled. And what I want to emphasize is the parents on our CAB were so open and honest with us, and they said, we want kids to be safe just as much as you do. You know, we're not saying not to make mandated reports or that this is always, but the way that it's done is problematic. And so how can we address that? So first, we need to think about representation and training. So within both the institutions that we have worked in, there are parent support staff that are there to really help if there is a mandated report or if there's other needs for parents. But the parent support staff are not very diverse and don't reflect the experience of those that they are often interacting with or asked to engage with. So how can we address representation in that way? Requiring staff who routinely make mandated reports to complete trauma-informed care and cultural humility training, making sure that we're really thinking about how we train professionals that are doing this work in a way that's going to best serve the families they're working with. Really increasing transparency and equity. So there was, and this I will say, just to be completely honest, is the hardest one to get the systems that we're advocating in to change, but really instituting ways that we can look at the data and be honest and transparent about it. So are there differences in decisions to file mandated reports for similar situations by race? What is the consistency of referrals for parent and family support services after a mandated report? Does this differ by race? Looking at this and routinely reporting this data, including plans to improve it if there are disparities, is what we're advocating for. Requiring that all families who received a mandated report are given parent support resources, taking the subjectivity out of it. This is just something we do across the board. We don't force it on families. We don't require that they follow up with these, but we make sure that we offer parent supports to everybody, because what we were hearing from families in our CAB and then also in our research was that there was not a consistent effort made to provide supports. It was very punitive. And then require that mandated report policies be easily accessible and understandable to families. So again, this real transparency element. So this was something that we, again, was a process, but we have our policy brief. We continue to advocate. We have seen some changes in the systems that we're working with. And I just want to end with one of our parent leaders who worked with us, her reflections on this experience. After growing up in this environment and always thinking that other people were having conversations about me, how to help me, how to make programs, it's such an experience to sit at the table and be a part of that conversation. Bringing the community into the decision-making and brainstorming process. I see this process as breaking the stigma of we are supported by you and you work over us. It's not I'm poor, I need financial help. Instead, it's we all have issues and are more alike than we are different. There should be more programs that allow people to be equal to one another, not about a superior group or a minority group, just equal. We are all sitting at the table. So ending with just some resources for folks. Again, you all will have access to these slides so you can kind of look at these further, but I just wanted to offer that because, again, this is ongoing work, cultural humility, and so I really encourage people to think about how they can access different resources and tools. I've talked a lot about some of these and how we've used them, but there's many more, and really encourage folks to really look at what's going to work for you and your environment and your own self-study. But fortunately, there are many tools and resources available to us to do this work. And now I think I left 5 minutes, but some time for questions and discussion.
Tasha, you need to unmute your microphone.
Thank you for all your help, Dr. Woods-Jaeger. We will now take any questions about today's presentation. As a reminder, you can still submit questions through the chat box in the attendee control panel. We do have a question here. So what is an example of a culturally insensitive treatment recommendation?
Yeah, so this, of course, depends on the client you're working with. I can share some things that have been shared with me. So I talked a lot about that work that we've been doing with parents. And a lot of the recommendations that they mentioned were really insensitive, that were more, I would say, probably socially insensitive, that they didn't understand what parents were navigating and what they were juggling to be able to implement some of these things. And so a lot of what it's not necessarily having to change the treatment, but how do we adapt it? So like with PCIT, for example, really looking at ways like they would give, asking them for the examples of when this comes up. So it's on the bus. Okay, we're going to really focus on how can you do this on the bus? How do you really, and this is already sort of built into PCIT that you wanted them to generalize it, but being open to hearing what the barriers are and really taking the time to understand and reflect on those before we jump into the homework for the week or the problem solving. So it's not so much, at least in that case, that it was the recommendation of it's culturally insensitive, it's the way that it's delivered and the way that these parents are approached in general. I do think deficit approaches tend to be clients are keenly aware of that. And so when they come into your space and just the way that we sometimes approach our treatments, that is an experience that turns them off and that really makes them not feel seen. So thinking about how we start with a strength-based approach while dealing with something that is very challenging for them and their family.
Thank you. We also have an additional question. Someone is curious as to where they can find the cultural identity inventory.
Yeah, so I guess I can't go back to the slides. On the slide that I showed at the end with all the sort of resources, one of the books there, it's the, is it Community Organizing and Social Welfare? It's the one, the yellow book, it's within that book. So Dr. Cheryl Hyde is who developed it. So you can also, if you Google that her and cultural identity inventory, it'll come up, but it's in that book. And then I believe there's actually been an update to that more recently. I'm not sure what book that one is in, but you can, again, by Googling, access that as well.
Sorry, Sasha, your audio's cut out again.
Thank you, Dr. Woods-Jaeger, and to all of our participants in today's training. We would like to invite you to register for ADAA's next live webinar on November 19th, The Practice of Cultural Humility, Addressing Privilege, Stereotypes, Biases, and Microaggressions in the Therapeutic Context, with Drs. Hong Nguyen and Elizabeth Saber. We also invite you to visit adaa.org to view all upcoming live webinars, as well as our full library of on-demand webinars. We would also like to invite you to the 2020 Virtual Fall Forum on Anxiety and Worry in Youth on October 29th. An interdisciplinary group of speakers will present on the biological and psychosocial mechanisms and interventions. And if you are not yet an ADAA member, we invite you to view the many membership benefits that ADAA has to offer, including year-long access to continuing education webinars with free CE eligibility, access to our special interest groups and online peer consultation groups, as well as significant discounts on ADAA's annual conference that will be virtual this year. On behalf of ADAA and our presenter, thank you so much for joining us today. Have a wonderful day.